my research on digitally screening PTSD in youth, and what I did with my research was conduct like a literature review on PTSD literature, and then I came up with recommendations for further improving this field of study. So, um, and my mentor was Corinne. So here's a table of contents. I'll go over biography first, and then I'll introduce and establish PTSD, prevalence, and importance. I will discuss the main body, which is I'll discuss PTSD risk factors, barriers to screening that exist, that prevent the most effective screening of PTSD. Then I'll propose like a project. So I'll propose like my suggestions, and then we'll have Q&A and conclusions. So first, here's a quick biography. So I'm in my third year. I'm a junior at Tacoma, Washington, where I live, and my school. And my academic interest is in clinical psychology or in health psychology. So it's pretty it's like aligned with this project. And I've used this project to delve further into my interests. And just a quick this is a picture of my hometown, And so I'd like to just jump straight into it. So this is the introduction, and I'd like to introduce post-traumatic stress disorder. And it's a mental disorder that's triggered by experiencing a traumatic event. And traumatic events include like violence, serious injury, natural disasters, interpersonal issues, death, and other serious events. And importantly, it's something where you feel threatened for your life, which causes like an event to be classified as traumatic. But also what's interesting is you can experience someone else experiencing these traumatic events, and still that would count as a traumatic event for yourself as well. So disruptive symptoms of PTSD include arousal symptoms. So this includes being agitated very easily, or you're over alert, or you're prone to angry outbursts. There's also avoidance symptoms, where you avoid people, places, or things that serve as reminders of the trauma. And people with avoidance symptoms, they go through very far lengths to avoid reminders of the trauma as well, in some cases. And there's cognitive symptoms as well, which is the negative thoughts about either the self or the world, such as like I deserve this trauma, or the world has done a great, like the world is out against me, something like very negative thoughts about that type of thing. Or there's also the inability to recall trauma. So this could be like suppressing memories of the trauma. But there's also guilt, like you feel guilty for the trauma that was inflicted on yourself, and also just a general disinterest in everything. And there's also intrusion. So these are the famous flashbacks of PTSD. Like PTSD is famously, like it's usually depicted as flashbacks, and that is definitely a core symptom of PTSD. And there's also the intrusive and recurring memories of traumatic events. So a person who has PTSD would have some level of all of these disruptive symptoms, and it's very clear that PTSD can have a very big negative impact on your life. And specifically, my literature review is focused on how PTSD affects children and adolescents. And we can see that exposure to traumatic events in childhood is common. Approximately 64% of American adults say that they've experienced a traumatic event at least once during childhood. And of these traumatized youth, 8% develop PTSD by age 18. And that is a significant, that's a significant level of prevalence. And it shows that traumatic events to PTSD is very much correlated. And this is from the DSM-5, which is where I also got the information for symptoms as well. And this is the DSM-5 is the leading manual used to diagnose PTSD. And so PTSD is very detrimental, not just because of the symptoms that you experience, but because of cognitive shifts as well. For example, PTSD impacts your brain development, and it's associated with a reduction in the size of your hippocampus, which is which is important to your functioning of your memory, which is why you feel which is why you get either the recurring memories or the repression of memories. It's due to the reduction in size of the hippocampus, and which changes its functioning in a very negative way, and makes it work in a way that is not supposed to. And there's also changes in regulation of the hypothalamic pituitary adrenal axis. So what this is basically how you regulate your hormones and how you experience emotions. And this is also this is called the HPA axis. It's very tied to how your memory functions as well, because it's all part of the limbic system in your brain. So this little diagram here demonstrates this perfectly. So there's a stressor from your trauma, and this impacts how your HPA works. This impacts cortisol levels, which is like your neurochemical for stress. This impacts how your memory works, and the specific mechanics of how PTSD impacts brain development is also very interesting. As a side note, it's called DNA methylation, but basically because you experience a traumatic event, your genetics literally like take a mutation, like they mutate based off of what happens to you. And it's a very interesting mechanism for how and why the HPA and your hippocampus all changes. And this is very critical because these developments have more impact when you're a young child, because young people and adolescents, that's the time period where your brain is actually constantly developing and making all these neural connections. And this disruption in your neural connections is creating a lot of future potential issues. And due to these brain changes, there are social consequences as well. For example, it impacts your academic performance. In literature that talks about like how PTSD and trauma experience impacts academic performance, they saw a major drop in GPA around basically like failing school, which is a very significant social consequence for some of these people that have PTSD. But there's also high risk of suicidality and suicidal ideation. And it's also linked to teenage pregnancy in women. So we can see that with these changes in brain development and these difficulty in emotional regulation and changes in your memory, this leads to social consequences. And interestingly enough, these social consequences can actually lead to further experiences of traumatic events. So your trauma experience leads to more trauma. Trauma begets trauma here in some cases. For example, there's another social consequence, which is like behavioral issues, behavior regulation issues that causes some people who have experienced trauma to actually get bullied as well. And bullying is it's very clear how that can lead to traumatic events, and how severe cases of bullying can even lead to further PTSD like diagnosis. So here are other PTSD risk factors. So there's gender as a PTSD risk factor, and this is actually interesting. Women have a different HPA axis, which is the hippocampus and memory regulating system, and this causes women to actually face higher levels of like getting PTSD from a traumatic event. And also women are like 97, or like a very high number, 97% of women face sexual assault compared to men. So women are the people that are at risk for like PTSD in relation to sexual assault trauma. So, and this is relevant because the more severe case of trauma means the more severe the trauma, the more like stronger the symptoms of PTSD are. So gender is a very important risk factor, but socioeconomics, or like the income level of your family, also determines PTSD risk factor, because if your family has a lower income, that results in actually more cases of traumatic experiences. And this makes sense because when you're in a low-income environment, there's lots of stressors put on both the parents and the children due to financial pressure, like difficulty paying rent, or your parents are off working a long time, or even in some cases, like your parents are, they make low income, but they also are like, part of that is because the parents actually themselves have mental issues or personal issues that causes them to actually abuse their children as well. So there's like a lot of different like causes and correlations between socioeconomics and experiencing trauma as a young child. And biology, I went into with your HPA axis, but there's specific genetic biomarkers in your DNA that cause like some people to be more susceptible to experiencing trauma. For example, like someone who has difficulty already has difficulty like regulating cortisol levels will be impacted by trauma more heavily, and they will be more likely to develop PTSD. And also pre-existing conditions also are a risk factor. So this is related to comorbidity, which is a term for like simultaneously going through like multiple mental disorders. For example, the most common comorbidity or pre-existing condition is depression. And it's actually very important that comorbidity is actually factored into screening tools, because depression, the symptoms are somewhat similar to PTSD, especially that lack of interest that is key to major depression. Sometimes that can get mixed up and you're actually not diagnosing PTSD, or you're missing the diagnosis of depression, when really a person can have both. So these 4 risk factors are also very, very important to implement into screening practices, but that doesn't happen in all cases, because there's barriers and limitations that exist in current screening tools. So here are the 2 most well-established and popular uses of screening tools. So the first is the Child PTSD Symptom Scale, or the CPSS-5, as it's abbreviated. It's the 5th edition, correlating with the 5th edition of the DSM-5. And it is internally consistent with Cronbach's alpha being 0.924. It's valid and it's reliable with an R value of 0.8. And it's an assessment tool used for the diagnosis of PTSD in children aged 8 to 18. And this clinician-administered PTSD scale, or the CAPS-CA5, this is also an internally consistent, it's an internally consistent, and also has good test-retest reliability with an R equal to 0.78. So the point with these statistics is people have rigorously tested out these 2 screening tools, and they found that these 2 screening tools are very, very good at diagnosing PTSD. So there are definitely merit to screening tools that already exist, and all other future screening tools, especially digital screening tools, look to adapt some parts and benefits of these screening tools. So here's what screening tools actually like look like. So this is the Child PTSD Symptom Scale is come in 2 forms. There's an interview version, and there's also a self-assessment. This is the self-assessment, because getting a picture of the interview, that's more difficult. But with here, you sign, you're actually writing all this out yourself. And perhaps like a clinician is like, just watching you do this and making sure like you're getting through it. But it ask questions like frequency, how many times a week you feel these symptoms, or you're answering questions like, how frequently do you have bad dreams or nightmares, or how frequently are you trying to stay away from anything that reminds you of what happens? See, this item is talking about that avoidance symptom. And all of these items actually target those 4 symptoms I've mentioned earlier: arousal, avoidance, and cognitive, and the recurring symptoms. All of these items target those. And so you can see how these items are they're based off of the DSM, the leading diagnostic manual, and what that results in is a very clear and accurate method for diagnosing PTSD. And I just like to mention that this CAPS-CA5, it's only purely in a clinician administered form, and we'll go into why that's actually important. And that's because PTSD is actually not being properly addressed. It's not being properly diagnosed. Only 28% of trauma centers in the US actually routinely check for PTSD, and other research and other literature established that PTSD is actually very much underdiagnosed, and this is bad because PTSD, as we've established, is both prevalent in society and also very harmful to the patient. And the question I want to ask is, why are we not addressing PTSD? It's due to these barriers I've been foreshadowing. There's language barriers, which is due to the fact that with clinicians, clinicians can't speak all of the languages in the world. So a clinician could speak primarily English, but because their patient speaks a different foreign language and does not speak English, the proceedings to screening PTSD actually cannot continue because the clinician these screening tools have developed like a Spanish version or a Portuguese or a Dutch version of their screening tools. But no matter how many different versions of a language tool you make, if the clinician cannot understand that language and read it out loud to the patient, there is no possible like interaction. There's no possible way to proceed with screenings. So this language barriers are an active like issue with PTSD screening in hospitals. Secondly, there's the patient-doctor hesitancy. So what this is because there's a lot of shame in society with PTSD and trauma and all these events, some patients may feel very uncomfortable with expressing their PTSD trauma. Not all patients. Some patients are very, very much okay with saying that like the issues they're facing, but some patients do face that feeling of hesitancy. And on the doctor's side, some hospitals are underfunded, and this leads to some doctors not getting enough of that training, specifically in PTSD screening, because you need a specific subset of like training outside of medical school to actually administer these PTSD screenings. So doctors that feel underprepared, they're going to be hesitant. And when the patient sees that, they're going to mirror that hesitancy. And that creates like a loop of where the doctor feels uncomfortable, the patient also feels uncomfortable because of what they see in the doctor and their own shame. And that creates like a loop that's very difficult to break. And of course, this doesn't happen in all cases, but this is this is an issue that exists in PTSD screening, and it serves as a major barrier. And thirdly, these 2 points are related, but it's like the strain that PTSD screening puts on a medical care system. Firstly, there's the high cost of administration because you're paying these doctors a doctor's time is very valuable, and however long it takes, that's like the costs exist. Like there's costs of funding the doctor, there's costs to funding the training that the doctor goes through before administering these screenings. But the most important and the most significant barrier to PTSD screening is the burden of time. And that's because the CPSS and the CAP-CA5 both take roughly 30 minutes. They take a long time. 30 minutes is a very significant amount of time, because if we think about it from a doctor's perspective, they are seeing multiple patients every single day. And by adding like 30-minute chunks, that time adds up very quickly. And that puts strain on the doctor, personal strains on the doctor, because they're having to administer these very heavy topics and very heavy screenings on these patients. And they're also putting strain on it's also a strain on the medical care system, because these screenings take such a long time. It's difficult to process a lot of these patients at once. And that is the most like significant reason to why PTSD is not being screened enough, and why PTSD is being underdiagnosed. So here's
Hi,
where
Aaron, sorry to cut you off. My apologies. I wanted to just be cognizant of the time. We're a bit over the 10-minute cap, but I'd love, because this is a really fascinating topic, and I want to make sure that you have a minute or so just to touch on kind of the final result of your project. So I want to give you the floor for another minute if you'd like to just sort of touch on that final result.
Okay. Apologies, that was
No, that's okay.
Yeah. So digital screenings come in because they come in multiple language barriers. They also sort of they add a layer of removal from PTSD patient-doctor hesitancy, because some people find it more comfortable to talk to a computer rather than a doctor, because that level of personalness is gone. And also it reduces the cost of administration, because it's very cheap to actually administer. You just give someone a reusable tablet and they can go through that PTSD screening by themselves. So a doctor doesn't even need to be there. It can just be a nurse practitioner. And that also definitely lessens the burden of time because the doctor doesn't need to physically spend 30 minutes. They can maybe just do occasional checkups on the patient. And literature shows promise for digital screening. For example, Masani et al.'s study on the CPSS5 screen team game, basically they adapt the CPSS5 and they create an aquatic and beach themed game where the patient plays engaging games where you swipe squid ink away to reveal questions, and it is very statistically reliable. So there's also various other applications to digital screening. For example, artificial intelligence. It can adapt to user responses, and they can basically act as the provider. And this is also a very cheap and alternative method to digital screening, to screening for PTSD. And they also can be used to analyze internet data and health records really, really quickly, as opposed to the doctor who has to probably take hours to analyze data and all of that. And if we look at the analysis of passive biomarkers as well, mobile devices and technology can measure heartbeat, it can measure the MRI scans, and it can create a lot of new ways to measure PTSD that have not been possible in the past, because we can now look at how your brain actually physically looks after experiencing a traumatic event, for example. So these new biomarkers are appearing, and artificial intelligence can actually be used to sort of further this field of research and create a new sort of digital screening tool. So now we're at the proposed study. So not an actual study that I conducted, because this type of study requires a lot of resources that I, a high schooler, do not have. So here are the participants of this proposed study. It's an adolescent population from 13 to 17 years old. And we chose this because they're both under the age of 18, but they can also most likely be able to read. And this being able to read the digital devices is a limitation that exists, but by selecting the participants carefully, we minimize the impact of that limitation. Secondly, there's they have to be a resident of the Inpatient Rehabilitation Center for Injuries. So this is basically filtering out for all people that have already have traumatic experience. So basically, that filter exists. So everyone that's already in this residency of Inpatient Rehabilitation Center have already experienced a potential traumatic event. And this is happening around 2 weeks after the traumatic event has happened. And the procedure is parents are asked for consent. Participants are going to complete the digital screening task that will be developed by the researchers of the study. And it will be, of course, modeled after trauma screening questionnaires and the DSM to create a most accurate digital screening tool. And additional measures that will be taken is the patient sociodemographics, that we can measure risk factors and the impacts of that. And also, we're going to have the patients rate the experience of the digital screening, and we're testing out the feasibility. We're testing out if people actually like doing this digital method instead of doing it physically or doing it by the clinician actually administering this screening tool. So we're going to be looking
Aaron,
at.
Apologies, I do want to be cognizant of the time. I did have one question that came through. It was actually just about, given your extensive research on PTSD, what advice would you give another student researching this topic?
Yes, so PTSD literature is very, very vast. So I would pick what I did was a general overview of the entire field, looking at risk factors and stuff. But I would recommend starting off with just that topic and finding all if you go to Google Scholar, just type in those specific keywords and just really focus in. And then later on, supplement your research with outside and more general information. That's my recommendation.
Awesome. Thank you so much, Aaron. I apologize for having to cut you short here, because this was a really fascinating topic. But thank you so much for presenting this.
Yeah, no problem.
Absolutely.